Good evening, everyone, or good late afternoon for those of you on the West Coast, and I imagine we have some folks from around the globe. So good morning to you all. But welcome to what if I'm counting correctly, is the fourth grand rounds. We hope you all are continuing to enjoy this as we share with you what's happened, what's changing, and hopefully answer some questions for you. Just a reminder, please don't ask about specific cases. One, that gets too close to a potential health data spill, but two, this is more a forum for transfer of that knowledge in case or questions about the subject matter.
So first of all, CME, the information on how to claim your CME will be addressed at the very end, but you will have to send an email to get to claim your CME. However, I will tell you right now, if you do not have your full first and last name on your profile, you will not get CME credit because we can't verify you were attended. So we'll talk about identifying the pilot's legal name. We'll talk about policy changes in neurology, some policy changes in ENT, a new dispo table, and khaki for psoriasis, the new disposition table for pectus excavatum. I don't even know if I said that right. And admin changes to processing ASI and ADHD standard track testing. And our first one up is Jana Weems talking about AMCS and pilot names.
All right. Good evening. Thanks, Deanne. So basically, I'd like to talk a little bit about this. Should you correct a pilot's name? So the AME guide, in accordance with 14 CFR 67.4, talks about the fact that it is required that applicants must show proof of age and identity. So checking that ID is part of the exam process. As you know, the name appears on page 1 in AMCS. So this is the data entry screen of AMCS, and item 3 holds the name. Also, what you may not realize, beside each little item number, there is a green OK icon. You'll click a couple times there, Deanne, they'll see that green OK. And if you click on that green OK icon, it's going to open up the AME guide in a separate tab. This is true of all item numbers, but the next slide will show you what it says about item 3, which is the applicant is required to use their legal name. So as we talked about, you're checking the ID, you're checking the application. You need to go to number 3 and check to make sure that the pilot has put their legal name correctly on their application. Based on the data I've seen, we frequently have pilots who transpose their name. They put their names in the wrong boxes. They put Joseph one year and Joe the next year. They leave out their middle name. There are all sorts of scenarios in which we are seeing what is not the person's legal name. So you've checked the ID. Be sure and check that name on the application. Verify it's correct. If it is not correct, please make the necessary corrections on that screen. If you will go ahead and just click next, we should see some animation here, Deanne. This is the comments page. And so on the comments page in AMCS, anytime you make a modification to the MedExpress application, you will be required to provide a comment. So in this case, you would see any changes that you made to the name. You would explain why you changed the legal name, and that's because you verified the ID and you made the correction for them. I recommend that you would upload a copy of that person's ID in the case that you have corrected their name. It just makes the package more complete, makes it more clear on our side. So please correct the name. Please explain the correction of the name. And in the next slide, we're going to talk about your next steps. Because if you do take that action and correct the name, your best practice is to follow through with these next 2 steps. Instruct the airman to update their name on their MedExpress account at or before their next application. The reason you need to do that is because if they don't correct it in MedExpress, you will be doing this all again in AMCS next time. So encourage them to go and fix their name in their own account. And number 2, if they are the holder of an airman certificate, if they haven't correctly documented their legal name change with a FSDO, they're going to need to do that as well. A change in our system does not meet the standard of correcting the name on their airman certificate. So if you have had to correct an airman's name on their application, if they do hold an airman certificate, they need to do their due diligence and make sure that name is accurate with the FAA's registry. So if you need more information about that, you can look up the Airman Certification Branch of the FAA and get more information. Oh, the best slide. Should you have questions about AMCS transmission, including how to change the name, contact your technical support team, AMCS support at FAA.gov.
We are now going to move to Dr. Hasselbrock with neurology.
Okay, good day, everybody, whatever time of day it is in your time zone. I'm going to cover a few changes that we've made to, again, refine guidance for the head injury tables and also a little bit with syncope and with headache as well, too. So is it a head injury? Does it also involve the brain as well, too? So we're trying to make a little distinction between somebody that scrapes their head and may get a laceration that needs sutures, for example, versus somebody that actually has a brain injury itself. So to try and tease that out, we would say the head injury only would not be a brain injury, would not be concussion, would not have neurologic symptoms. So basically just somebody that has either bumped their head, scraped their head, things like that as well. So pretty narrow definition in here as well. So that one really is pretty easy. If it fits in that particular category, if all these criteria are met, then you have the green light as the AME to go ahead and issue at that point there, and you can annotate that in block 60 accordingly. Please define concussion here. Boy, that's a difficult one to do over here, and I'd rather not get into it right at the moment until I get to the end of the presentation. So let me leave that to the end and address that question later here. In our table, we'll talk about concussion being a type of mild brain injury here. What we've done with our second section, or row B as we call it here, we wanted to break out the milder injuries that have occurred more than 5 years ago and allow you as AMEs to certificate some of these and not have to defer all of them to us to incur additional waiting times, et cetera, on that too as well. So this would be an injury that happened 5 or more years ago. And the only ones that we're including here are the airmedically milds, which would be less than 1 hour of amnesia, loss of consciousness on that, negative imaging, or somebody who's had a head injury with symptoms afterwards. Generally, with a concussion, you would see varying degrees of either headache, possibly some mild cognitive changes, and they would generally be brief and self-limited in that regard as well. Now, what we've also put in is if someone does have a head injury and they have a seizure immediately at the time of injury, that actually has no negative connotation as far as developing post-traumatic epilepsy. And probably won't see too many of those, but this will at least give you some leeway to look at people who have had those remote injuries. So again, this would only be the milds or the concussions. Be very careful because the community docs will label a lot of things as concussion or mild injury, and they're not. So don't just stop there. If the person had a skull fracture, that's not a mild head injury, that's a moderate. If they had an epidural hematoma, that's not a mild head injury, that is a severe head injury. I just looked at a case today that had skull fracture with epidural that needed emergent evacuation. And a neurology colleague in the community labeled it as recovered mild head injury about 20 years after the fact. It was not a mild head injury. So be careful because yeah, make sure that it fits these defined criteria here, and then you're able to go ahead and issue at that point. So we've teased this out as a separate row for the remote brain injury, made it a separate little table, if you will. So what was previously labeled B is now B2, and this is B1. Next slide, I don't know if you have B2 on there or not, or if that's okay. This is a decision tool that we came up with for remote head injury. This is not one that you have to submit to FA, but it's one that you can use as a tool to go through to help decide, can you issue these or not? So you can see, did it occur within the last 5 years? Did you have any of the criteria that would define mild head injury or worse? Were there seizures that occurred 24 hours or more after the injury? That's the limit for what we would call an immediate seizure, if you will. Now, why do we put in here on number 4 a high impact or penetrating force? Say somebody gets grazed with a bullet, for example, that can impart a lot of force to the brain through the skull, even if it may not cause a significant skull injury. And so we worry about that, and we'd prefer to look at those cases just to be sure they might not need cognitive assessment, for example. Big one here, if there's imaging that was done, did it show evidence of blood products within the brain? And if that's the case, or a skull fracture, or what they would label maybe as diffuse axonal injury, those are ones that you should not certificate, and you should defer those on as well too. Of course, question 6, do they have any current cognitive or neurologic symptoms, any abnormalities on examination? They should be asymptomatic at the time here. And then the wastebasket question 7 is, using your AME sixth sense, do you have any concerns about that pilot, that aviator? If you do, then don't certificate and defer on to us as well too. So the question would come up, what about the individual who's had a bunch of sports concussions, playing soccer, playing football, or if they're one of the service academies or in the military doing combatives, or multiple blast injuries during deployments and that? If there are multiple injuries, each one has to be no, and we're not going to take the multiple injuries different than the single, but we'll consider each one on their own. So if each one of those, let's say 5 concussions or 5 mild injuries that they've had, are negative for everything, then they're good to go. But if one of them falls out of that criteria, then you've got to defer for that. If there's questions as far as the application of it, certainly let us know in that regard. But this should allow some flexibility to take care of some of these older injuries that are on the milder side here, and not have to defer all of them. So this is on syncope, which is not my favorite subject. I'll be transparent with you there. I don't think anyone really likes dealing with it so much, but this one's for me to talk about today here. What we want to look at is cover what you'd be able to issue as an AME and what else you may need to do as well. So if you look at A under here, is there a defined cause? So for example, were they very dehydrated? Were they not drinking well? Was it on a hot day? Was it orthostatic related? Did they bang their finger when they were hammering a nail in and become pale and lightheaded and faint because of pain? Did they see some blood? Things like that. Something that you could really pin down as a cause there as well. And that's somewhat of a judgment call here, but if it would be compatible with a situationally specific vasovagal event, then you would be able to potentially issue that. However, if you don't have a really good cause for it, if it's a sudden onset, if it's multiple, then you need to defer those. Now, for syncope, as a neurologist, it's pretty rare that I'll find a primary neurologic cause for syncope. The main concern is, could there have been some abnormal movements that occur and could be confused with a seizure, or potentially have seizure as a diagnosis? A lot of times it's more in the cardiovascular realm that's a cause for syncope. So unless there's something in the history that would make you suspect a primary neurologic cause, we would recommend having the first evaluation be done through the cardiology to make sure there's not an arrhythmia or a structural problem that might be a factor there as well too. And if that's negative, or if you're worried about a neurologic event, then you get a neurologic consultation and evaluation here. And then the question comes up, well, what about the person that's found down, the unwitnessed episode? Well, then you're stuck. Then you may have to do both in here and do more of a shotgun approach. But if you can get supportive evidence from any witnesses that might have been around, that might be good. Realizing that if it's a non-medical trained witness, anything that moves or shakes may be interpreted as a seizure. So take that with a little bit of a grain of salt there as well too. So that's syncope. I'm not going to harp on that very much more over here. We'll move over and talk about, okay, so again, syncope here, if the cause is unknown or unexplained, initially we look at the cardiology evaluation, and if the cardiology evaluation is negative, then that's where we would look at potentially having a neurology assessment to see what may happen there. Unfortunately, this is one that if we go through the whole gamut of workup and you don't find a particular cause, which is unfortunately more the rule than the exception with syncope cases, we may have to put this in the category of a unexplained transient loss of neurologic function or consciousness, and that could incur up to a 2-year observation period to make sure nothing ominous happens in the meantime as well too. And then what about if someone has a syncopal episode and then they hit their head? Well, then you've got two things to worry about. You've got the syncope and you've got the head injury. And so you have to look at those separately too. So the syncope may warrant one particular evaluation. The head injury may incur different evaluation or observation period depending on the severity of it. For example, I've seen a couple of cases of people that had venipuncture done, and they felt okay at first, but when they got up, they passed out, hit their head on the floor, they get a skull fracture, get an intracranial bleed. So you have to worry about that, and that's actually maybe the worst part than the syncope itself. So you have to make sure there's not a concomitant head injury or other confounding factors as well. So those defined criteria for syncope, well explained, isolated event, solitary event, that's really the only ones that you would be able to certificate yourself as the AME. Anything else would have to be further evaluated or sent up to us as a deferral. We've made a few changes to the migraine CACI. We've tried to refine a little bit of the terminology. Unfortunately, there's still a lot of what we've considered maybe not current terminology out there, such as acephalgic migraine, ocular migraine, ophthalmic migraine, classic migraine, common migraine, et cetera, on that too. So we're trying to streamline that a little bit here so that what would be included in the CACI would be the migraine with aura or the migraine without aura, or the tension headache or daily headache here. And then there's the worksheet that will go through. And if they do meet the criteria under the CACI worksheet, then you could note that in block 60 and say, CACI eligible and issued. And we leave it at that here as well too. Again, as with any other CACI, it's incumbent on you as the AME to do the appropriate review and verification of any information to ensure that you're signing off appropriately. What we have done in the CACI worksheet and some of the areas that are highlighted in yellow here, in addition with Dr. Vicky Q, we've expanded some of the medications allowed here. And under the preventive medications, we've also, in addition to the antihypertensive medicines, we have put down the CGRP agents that are used as preventive medication. We'll talk about that more in a little bit as well too. And also under the acute treatment, we've also put some of them down as well. And then the no-fly period that would need to be done after one of those is in place. We have also put down if someone's using one of the stimulator units like Cephalí or Gamma Core, that these could be acceptable with is it preventive use with an 8-hour no-fly, and if it's just an abortive use for acute care, 24-hour no-fly with the thought that that's not being used on a daily basis, if you will, there. So not too many people will be using them, but a few people will. So if you encounter them, that would at least give you the option of potentially certificating some of them and not having to defer all of those to us. So this is an update on the medication page for migraine for preventive medications here. So again, it's reiterating what you saw on the worksheet here, but this also expands it to talk about the ground trial that would need to be done, and then if there's any no-fly period afterwards. So the antihypertensives would not need a no-fly time after use. Actually, none of them will, but these would need a ground trial of 7 days. If someone is getting Botox for treatment of chronic migraine or chronic tension headaches, that ground trial would be for a month, and then it's a 72-hour no-fly after each dose. So why is that? Well, it takes about a week after you get your Botox injection for it to basically peak, and you would have the nadir of symptoms that would be occurring as far as muscle weakness if it's going to occur, systemic symptoms. So this would allow a good amount of time after your initial trial period to see, first off, are you going to tolerate it? Are you going to have any acute side effects like anaphylaxis, allergic reaction, or are you going to have a delayed side effect that would occur? Now, if you're already on a maintenance plan with Botox, that usually means you don't adjust the dose up or down. You pretty much stay at the same dose from treatment to treatment. And if you have a defined history that has not shown you've had any untoward effects, that's why it's only a 72-hour wait after the follow-up injections for Botox. And then under the red here, we're talking about the unacceptable agents for migraine prevention. So tricyclic antidepressants, anticholinergic effecks, cognitive effects, we worry about that. The anticonvulsants such as gabapentin and lacosamide, lamotrigine, any of the anticonvulsants, we'll worry about them again for CNS effects as well too. That would include pregabalin, Topamax, Depakote as well too. So we have those listed as unacceptable. And the abortive treatments. So if you have someone that's taking the oral agents for CGRP like Ubrelvy or Nurtec, that would be a 36-hour no-fly for Ubrelvy and a 72 for Nurtec. Nurtec's got a little longer half-life, which is why the longer wait for that one is. The triptans, the shorter acting ones are 24 hours. The longer acting ones, which would be Relpax and Frova, those would be a 72-hour wait because they have a much longer half-life in here. If anyone is still taking Cafragot or DHE, like Migranol, for example, these would be permitted with a 24-hour wait for basically Wygrain or Cafragot and a 48-hour for Migranol, the DHE. You're not going to have too many people that are on that. Those are more historical, and with the CGRP agents and the ditans becoming available, very few neurologists would be putting anybody on that now. These would be historical, if you will. Now, if someone uses Reglan for nausea relief, that would be a 36-hour, and then if someone uses Phenergan, that's a 96-hour because that one hangs on for a little bit longer here too. If you're looking at the ditans like Rayvow, that's a 48-hour wait. If you're looking at Toradol, that's a 36-hour wait. And then on the unacceptables, then you'd be looking at the Fiorinol, Fioricet, anything that has butalbital in it, the opioids, and then Midrin as well, isometheptine, because again, the central effects that would be occurring with them too. So it doesn't include everything, but this at least gives you a little bit more expanded armamentarium to look at on medications that you can issue. We can still look at others on a case-by-case basis for special issuance, and we do, but at least this gives you a little bit more flexibility there. I think that's the last one for mine. Let me go to the Q&A session here. Okay, so again, concussion would be a head injury with it would be more self-limited, and you may have a brief loss of consciousness. I don't like the term concussion myself. I prefer to say, did someone have loss of consciousness or not? But you can have people that would have like momentarily being stunned, or they may, if you will, see stars, or define it as having their bell rung, something like that too, where they don't have defined loss of consciousness or amnesia. And how far back for syncope? Unexplained events way back, like in childhood. Well, that's where you'd have to use your judgment as well too. And technically, if someone mentions that, then you need to go down the route and say, if you have a concern, then you can always defer those cases as well too. Many times you're not going to get any information about people that have had syncope as a child, or they may say, well, I saw blood, or I hit my hand, or had something like that happen to them, and they passed out, or I didn't eat or drink before I went to church, and it was hot and I was overheated and I passed out. Those I think would be more judgment call in here. Okay, the question, why 36 hours for Toradol? I think that's to allow any particular central side effects to settle down on here. And I would have to defer anything more to the pharmacology folks on here, but that's the answer here as well. And it looks like Dr. Murphy has mentioned a concussion has, quote, concussion symptoms. So there you go in that regard too as well. So the next one was about Qulipta is one of the CGRP nasal spray for abortus. Those would be okay, but we want a special issuance that. We just don't have that under the khaki yet. It may come at some point in time, but that's a little bit newer agent. So we want to give that a little more time, and that may be incorporated into the next iteration as we go along here. So it would likely be special issuance, but we want to look at that one as well. And as Dr. Murphy keenly points out here, head injury could cause a, pain, but localized pain, not really a concussion symptom here. So I think we have that listed. Okay, anything else question-wise for me? If not, I'll turn things back over to Dr. King, and I appreciate your attention, and hopefully these new changes will work out. If there are further changes that will help you all, then please give us the feedback and we'll look at incorporating that in the next iteration. Thank you.
Thank you very much, Dr. Hasselbrock. And so up next is Dr. Sigmund.
Thank you, Dr. King. Thanks, Roger. I'm Jason Sigmund. I'm the otolaryngologist and medical officer in Aerospace Medical Education Division here in CAME in Oklahoma City. And good evening to the audience. We have just 3 slides with some updates for you, all within the purview of ear, nose, and throat, and the 67105 section of your Part 67 standards. First of which, 3 disposition tables, which we'll share with you on these following slides, beginning with the one that you see now, which is our new disposition table released today for allergies and anaphylaxis. Again, it's fairly consistent with the guidance that everyone has been familiar with. It's laid out more formally for you in the specific disposition table with some information to hopefully clarify the sometimes confusing issue related to the use and utilization of EpiPens. In box A, you see in general, this applies to the majority of individuals and pilots that you'll see who have a history of allergies that's been formally diagnosed with either an ear, nose, and throat allergist or a medical allergist, that are controlled with acceptable medications that we provide for you in the AME guide, and or are on immunotherapy, traditional immunotherapy with injection immunotherapy or sublingual, which is more widely utilized. I'm sure everyone's aware. Oftentimes, if home administration or as a requirement of the allergist, the pilot may be required to have a prescription for an EpiPen that they bring with them to the office, or if they're self-administering EpiPens, if they're self-administering their allergy immunotherapy at home, which happens sometimes. About 15 to 20% of allergists will allow their patients on maintenance to self-administer with some direction and guidance. Their shots at home, and of course, we like those individuals to have an EpiPen. If you can go back, Deanne, to that previous slide, it got clicked forward. There we go. Then that's fine. We can issue. Make sure that again, under our understanding of the regulations about expected to a condition that might be aggravated by flying, and those are listed out there for you just as a general reminder, as a discussion point with your pilots about the environment in flight that could exacerbate conditions that aren't present on the ground, such as Eustachian tube dysfunction and sinus lock, and even this alternobaric vertigo or dizziness, those types of things. But as long as it appears stable, discuss, again, this is the opportunity to provide some safety promotion through education about medications. And we have a nice a PDF that you can find in the AME guide that can be printed off about common over-the-counter medications. And that typically applies both to this disposition table for allergies and patients with allergic rhinitis, and also the next one that we'll discuss with sinusitis, acute and chronic sinusitis. So take that opportunity if you can to provide them with information about initial observation times. Just as a reminder, any the pharmacologic effective over-the-counter prescription medications we all know and recognize are very individualized. So anytime someone is taking a new medication or over-the-counter medication for the first time, we like to discuss this observation time just to make sure that that particular medicine doesn't have any side effects for them. But then we have specific no-fly wait times that are in the guide for you that you can share with them with that handout. So issue those. If we have in Block B, B and C, this obviously represents individuals who have immunologic IgE-mediated allergic conditions that are unstable. And those are manifested by in B and C under the bullet points. We all recognize what that looks like. It's associated with the chronic or repeat steroid rescue, requiring medical intervention, or in general, just the use of an EpiPen. In those cases, right, they have some more general systemic effects as a consequence of their allergies with allergic reactions that manifest in the skin, and we'd like those deferred. And certainly the history of anaphylaxis or allergic reactions that required the use of an EpiPen, please go ahead and defer those and let us evaluate those and come up with some type of a special issuance so that we can be, for aviation safety concerns, make sure we're monitoring those appropriately. This next slide is our sinusitis. Again, we have Block A's are acute infections. It also mentions deviations of the nasal septum or abnormal exam findings that show up on the ear, nose, and throat portion of the AME examination that sometimes generate questions. We're not concerned about deviations of the nasal septum or structural abnormalities as long as they're functionally fine and they're not aggravated by flight. Again, acute infections are common, and we rely on the 6153 regulations for our pilots and the things that they're taught regarding I am safe checklist and self-grounding and self-evaluation for infections and colds and those things that happen throughout the course of life. But certainly those conditions that are acute and are infrequent, and then we can issue. For our chronic infections or severe infections or complicated history, if we manifest by some of the ORs that you see in B under the disposition table, where they really struggle all the time with changes in barometric pressure, with sinus pressure, sinus pain or discomfort, eustachian tube discomfort. They're on chronic medications. Some patients with chronic sinusitis will be on oral antibiotics for extended periods of time, some protocols upwards of 30 days or longer, or sinus obstruction from nasal polyps that are significant and block off nasal airflow. Those we would like the opportunity to evaluate here in AMCD or within the regions. And so go ahead and defer those for us, and the evaluation data that we'll be looking for that can help move that evaluation along more quickly includes the information there about a detailed clinical progress note. We'd like that to be from an ear, nose, and throat specialist, or if it sometimes the allergist will manage these, that would be appropriate to give us a better understanding in a detailed clinical progress note about what's going on. Now, I think one point that we discussed about chronic sinusitis is we really want to make sure it's clear that if an airman comes into your office for an AME examination and they have a history of chronic sinusitis, don't mistake that for B. If someone has a history of chronic sinusitis and it's been previously surgically treated, and we all recognize that patients with chronic sinusitis oftentimes will have a history of multiple surgeries in the past. If they have a history of chronic sinusitis, they don't actively have any problems and they're stable, then just note that. Just say they have a history of chronic sinusitis. Maybe provide that information in Block 60, just so we're aware. But please go ahead and issue those pilots. It's very common. Individuals will have a history of chronic sinusitis that have had surgical treatment in the past. But what we're really talking about in this group in B are those who are actively persistent, having chronic recurrent acute sinus symptoms that are unstable. Those are the ones that we'd like the opportunity to evaluate. Our final disposition table is on speech impediment. Again, in 67105 we have there's in the federal regulations under the ear, nose, and throat examination, one thing is clear there, that effective communication is an important part of aviation safety for obvious reasons. Communication with flight crew and then the cockpit. In the first block of that disposition table would be individuals who maybe had a surgery or surgical treatment in the past that affected their communication. We'll certainly see that sometimes with anterior cervical disc or fusion surgeries, anterior cervical approaches to the neck for and anterior neck approaches for thyroidectomy. Someone could have a recurrent laryngeal nerve injury and have a period of time where they can't communicate. If you all can determine that that's resolved and it doesn't impair their voice communication, then please issue those. The B would be our conditions that include those who have a longstanding issue with a impaired voice communication, oftentimes through stuttering. We'd like the opportunity to evaluate those airmen, so please go ahead and defer. We'd like to have information from the speech and language pathologist, giving us a better understanding of how long the problem has been present and the prognosis and the things that are provided for you there in the evaluation data. You do see that there are a couple of indices, more objective data points that are available from the speech and language pathologist to provide for us. And those are the stuttering severity index and the speech fluency intelligibility test. So those are available metrics. And so you could share with, or certainly we will share that with our communication with a deferred application for a pilot for us with the speech impediment. We're going to, to the extent that we can do that safely, then we're going to provide some special issuance. But we would like to evaluate that and have some of those data points that are provided for you there in the new evaluation table.
Super. All right. Thanks, everybody, for being flexible. Thanks, Dr. King. So we're just going to go over the last couple of slides. Go ahead and go to perfect. So we have a new psoriasis disposition table. We've been asked by multiple AMEs, what can we do with psoriasis? Some of the meds are similar to the psoriatic arthritis, but this is specifically for cutaneous psoriasis. Row A, like a lot of row A's, topical medicine, no problems. AMEs, you guys just issue. Row B is designated for anybody who's on meds. Could be a single med, could be a multiple med. That's where the khaki comes in. Row C is specifically for the type of psoriasis that's more concerning, erythrodermic, pustular, or severe. So on the khaki, what you're going to see is an expansion of the meds that are allowed. We want a progress note from the treating physician. We list the type of psoriasis that's allowed on the khaki. Lab is only required if they're taking methotrexate. So if they're on one of the other allowed meds on the CACI and they're not on methotrexate, they don't need lab. And then if you look at the bottom of the page, you will see that it's split into topicals, methotrexate, and then any single biologic after a 2-week ground trial. One of the questions we've been getting from pilots is what's the downtime? AMEs have been asking what's the downtime. So the downtime is actually listed on the CACI worksheet now, so you only have to go to one page. Remember to talk your pilots down in case they don't end up on a CACI. There's always another option, and in this case, the option is an AASI. So if they don't CACI qualify, they could potentially qualify for the AASI. They just need to see a rheumatologist or a dermatologist. They need to tell us if there's any comorbid conditions. The ones we're mostly concerned about are cardiac and diabetes.